Good morning. Today's class is on approach and examination of a cerebral palsy child. When you hear this title, in the beginning it seems very complex. To examine a cerebral palsy child, students feel it is a very complex thing and they fear to examine a cerebral palsy child. But if you follow a clear structure, it becomes very systematic. So today I will teach you a structured way to approach a CP child in your practical classes. Starting with the definition, cerebral palsy is a static encephalopathy due to permanent and non-progressive lesion of the developing fetal or infant brain, which leads to a permanent disorder in the posture, movement and tone. And hallmark of CP is motor dysfunction. That means abnormal muscle tone, posture and movement. So motor system examination becomes very important in a cerebral palsy child. Let's see quickly the site of brain injury which can occur in a CP child. So it can occur in the cortical region, subcortical region, periventricular, basal ganglia, cerebellum and brainstem. So depending upon the site where the damage has occurred, the child will be presenting the clinical features. If the lesion is in the periventricular area, there is periventricular decumulacia which results in spastic diplegia. If there is stroke in utero, then hemiplegic CP occurs. If there is multifocal encephalomalacia, then quadriplegia is the type of CP, which is the one of the most severe form of CP. And cerebellum is affected, then ataxia. If basal ganglia, thalamus or putamen is affected, then there is dyskinetic cerebral palsy. Now come to the diagnosis. Diagnosis is essentially clinical. So soon after you look at the child, you should be able to make out this is a cerebral palsy child because the posture is so much typical. Then detailed history of high risk group infant is very important for the diagnosis, and a very careful physical examination where neurological and developmental examination is very important. So step by step I'll teach you. I'll just brief everything in detail. Starting with the history. In the history, mother usually complain of delayed milestone. The child is not sitting, standing or walking till date. That will be the complaint. Another is they notice the awkward looking faces of the child compared to her other children. And some others, they complain of spasticity of the child because the child gradually start becoming spastic, so they complain of this spasticity. And some, they say not gaining weight because the child is having nutritional deficiency. And then another is they may have swallowing difficulties, so their nutrition status is poor, and sometimes the child is not using the parts of the body properly, so there is disuse atrophy. So mother will complain. These are the few complaints which is given by the mother in the history. Then you should strongly suspect and proceed with the further history. Before you go to the history, you should know the etiology, because in history you should start with the birth history, that is antenatal, natal, postnatal history. So in this there are risk factors, so you should highlight all these points in your history. So prenatal period, the etiologies can be congenital cerebral agenesis or anomalies, maternal infection, important, torch infection, chorioamnionitis, maternal sepsis with UTI or high fever. So in antenatal history you should be asking all these things. Maternal exposures to toxemia of pregnancy, irradiation, drugs or alcohol. And then antepartum hemorrhage or infertility treatment. Then during the perinatal period, perinatal is 22 weeks, gestation age till 7 days after birth. So during this phase that the birth part comes. So here you ask about the birth trauma during the delivery, perinatal asphyxia, which comprises less than 10% cause for CP. And then if the child was low birth weight or was a premature birth, and if the baby had a intracranial hemorrhage or periventricular leukomalacias. Carnicterus is another cause, dyselectrolytemia, that will present with the seizure, and then sometimes they have a record of NICU admissions, and prolonged obstructed labor. So NICU admission is very important in your history. Then comes the postnatal causes, where infections like meningitis, encephalitis might be responsible for CP, might be the cause. Trauma like head injury or subdural hematoma, and seizures due to hypoglycemia, dyselectrolytemia, hypocalcemia during the postnatal period, or carnicterus after the neonatal jaundice, or cerebral vascular thrombosis, that is thrombosis of the cerebral vessels leading to stroke, and if there was a gross PM in the early infancy during the development of the brain. So these can be the causes for CP. So in the history, in detail, you have to ask about all this. And then many conditions, there is no defined etiology. So in these conditions, you just think there might be possibly some subtle brain malformations. And in the history, you should also know the early markers of the CP. So if the child comes to you at 6 months of age, you have to go in detail about all the birth history, and then you have to highlight all these early markers of the CP. You have to ask the mother. So the markers of CP can be excessive irritability, high-pitched cry, which is unexplained by any other diseases, extreme sensitivity to light, delayed developmental milestone, development of hand preference before 1 year, right-handed or left-handed, that should come only after 1 year, but if that preference comes before 1 year, then this is one of the marker of CP. If there is a lack of auditory response, child is not responding to sound or name, and seizures or poor suck, poor quality of sleep. Many mothers, they complain of this, baby is not having good quality of sleep. Another is lack of alertness. Another is roving eyes, poor hand regard. Hand regard should come by 3 months. So if the hand regard is not there, then persistent squint. Others are slow head growth. If you find in your measurements, if there is a microcephaly, that will also hint the child may have a CP. Poor neck control, persistence of the primitive reflexes. So all these you'll see in the examination part. Abnormal muscle tone and posture. If the child drags feet like commando crawl, or if the child has a toe walking during the development. Cortical thumb, so constant fisting of the tongue of the thumb, like you see in this picture. The child is fisting and the thumb is drawn inside of the hand. So cortical thumb beyond 8 weeks. Till 8 weeks this is normal, considered normal, but after 8 weeks this is not normal. Then if there is paucity of the limb movements, if there are stereotypic abnormal movements, and if there is a scissoring of the lower limb. Scissoring, it looks like this. When you lift the baby through the arm, and if the baby has a legs crossed like this, so this is a scissoring sign, scissoring of the lower limb. This is because of the spasticity. So history taking, you start with the history taking. So antenatal, birth history, natal, postnatal, you consider all these above points. Then in detail you ask about the developmental history and then associated problems. Suppose the child is 6 months, then you have to ask the development starting from the birth, whether there was a neck holding at 3 or 4 months, so that way. Same with the fine motor, and then social and also language. So that way you take a detailed developmental history of the past till date, till today's date. Then you ask about the associated problems. There are many associated problems I'll be discussing later. So those also you have to include in your history and also in the examination. For diagnosis of CP, certain criteria should be present. So those are delayed milestones. Another is persistence of primitive reflexes. Another is failure to develop postural reflexes. So these you have to do in the examination part. And there should be no evidence of progressive disease. And there should be no loss of milestones acquired previously. So if the child has already acquired milestones, child is walking at 1 year. If there is a regression of my milestone, the child stops walking, stops sitting, so those should not be present. Now the examination part. This is the main structure. Number 1, you do the general observation. Number 2, you do the vitals. Number 3, take the anthropometry, and which is all different. You should be taking differently from the other normal children. Then do your head to toe examination, where you have to notice all the deformities. Then number 5 is the neurological examination. This one is the main and very broad examination part. Then you assess the functional. So functional assessment should be done. Lastly, you should be seeing the associated problems. So remember these 7 points as a structure for your cerebral palsy examination. Let's start with general observation. Here you'll just see the consciousness. So everything in general, it's difficult. So just see the consciousness, whether the child is irritable, alert, not alert. So that way. And posture is very important. So posture in detail I'll discuss later. So posture, in what posture this child is lying. And then if the child is having abnormal movements while you are observing, then observe for the facial asymmetry or the dysmorphism. And if there is any drooling of the saliva, and general nutrition status. So just head to toe you give a general observation, putting all these points in your mind. So these can be the different postures in a cerebral palsy child. Decerebrate, decorticate, scissoring. So all these are different postures. So here the body is stiffened like a board, and then there's almost arching of the back. So these are the different postures. Here the child is so much hypotonic. So this way you'll see the observe the child in the beginning. After that, take the vitals as usual you take for other children: temperature, pulse, blood pressure, respiratory rate, and then SpO2. Then do the anthropometry. This is again different for the cerebral palsy child. You take the head circumference, see if there is any head deformities there also. You can take the anterior fontanelle if it is open, the measurement. Then you take the weight of the baby. Since the child cannot stand, many cerebral palsy children, they cannot stand. So here you take weight of the baby mother together, then you minus the mother's weight. That will give you the baby's weight. Then length measurement. Since they cannot stand, you take the length. Length also it is taken as a segmental because there might be deformities. So you take the segmental measurements like upper segment, lower segment, and if there is deformities, contracture in the knees, then part by part measure all, and then total will be the length of that child. Then take the mid-upper arm circumference for 6 month to 5 year old children to assess for the nutrition status. Then you do the head to toe examination as you do for other children, and here facial dysmorphism is very, very important. Posturing you should keep in mind, and contractures when you are doing the head to toe examination, and general skin survey is always important. After that we go with the neurological examination. This will be conventional neurological examination because nervous system examination is totally different for the cerebral palsy child. So start with the higher mental functions. So here the in detail like you do for other children is not possible because the child will not be obeying your command or will not correspond with you, cooperate with you. So see in general the consciousness, activity, how alert the child is. So that way just the general part you can see. After that you will do the cranial nerve examination. That is also as far as possible. So broadly, mainly by inspection you should try to cover up the cranial nerve examinations, because in cranial nerve examinations you have to give instructions to do the examination which the child is not going to follow you. So as far as possible how much you can do, you will do, and then present accordingly. Then comes the motor system, which is the most important part of the nervous system examination in cerebral palsy child, and here also there are special technique for the assessment of tone, power, reflexes, and then you should check the coordination. So in the motor system, muscle strength, movements, coordination, posture, balance, these are very important. So this special technique, now I'm going to teach you how you're going to assess. So number one, you should observe. Observation of child in different posture. So start with this. In different postures, you should examine the child. In the supine posture, you can see the posture how the child is lying. Here you can assess all these points. Morose reflex, asymmetric tonic neck reflex, rooting, sucking reflex, palmar-plantar grasp, cross extensor and glabellar tap. So all these can be assessed in the supine posture. Then pull to sit, where you'll assess for head lag, grasp reflex again. Palmar-plantar grasp also you can do, mainly the palmar grasp, because you're holding the child's fist. Then sitting posture, you can see the lateral tilt, arching of the back. Then you take the child in ventral suspension. Ventral suspension you can check for the Landau, Gallant reflex, parachute reflex. Mainly Landau parachute is important. In the prone position, you can see the head lift of the child, how much the child is lifting the head. Arm support. So arm support will give you the symmetric tonic neck reflex. And then writing reflex also you can check. Then in the vertical suspension, you'll see the child. Here you'll see the scissoring, walking, stepping, placing. So all the neonatal reflexes, I have taken a separate class before regarding the neonatal reflexes in detail. So you can go back and check that lecture, how you're going to elicit all these reflexes. Assessment of tone. That will be Emil-Tisson method, that is applied only for the infants. So if the child is infant, then you check these 3 points. Just check the spontaneous posture, how the child is lying. Then you need to see active tone. So here spontaneous movements in response to stimuli. Just give a slight stimulus and see spontaneously how the child is moving the limbs. Then you check the passive tone. Passive tone is resistance of extremity to certain maneuvers. So here usually the angles are measured. Adductor angle, popliteal angle, you'll see for the scarf sign, heel to ear maneuver. So this will show you the tone of the child, whether hypotonic or there is a increased tone. So this is done only for the infants. Then test for developmental reflexes. So here start with the primitive reflex and then check for the postural reactions. So in the cerebral palsy child, you start with the spinal cord reflex, which is persisting in the cerebral palsy child. So the spinal cord reflexes which you should check and which is persisting in the cerebral palsy child is flexion withdrawal, extensor thrust, cross extensor reflex, stepping and placing. So flexion withdrawal, just pinch the sole lightly and the baby will flex the knee. Extensor thrust, which is also known as magnet reaction, you pinch or just give a push in the flexed leg, you'll see slowly there is extension of the leg. Then cross extensor reflex, one thigh is stimulated, that time opposite limb will adduct and there is an internal rotation. Stepping, placing. In detail regarding all these reflexes I have mentioned in my class in primitive reflexes or the neonatal reflexes. So this spinal cord reflexes is persisting in a CP child, so you should check all these reflexes. Next reflex you'll check is brainstem reflexes, which is also persisting in the cerebral palsy child. So these are asymmetric tonic neck reflex, symmetric tonic neck reflex, Morose reflex, rooting, sucking, swallowing, palmar-plantar grasp. Then you check for the positive support reaction, where when you lift the child vertically with the feet touching on the flat surface, child bears weight on the leg for short time. And then another you check is negative support reaction, where when you lift the child up, then the legs is flexed in the air. Then you check for tonic labyrinthine reflex, where the child is trying to bring the head in midlines. It is one of the balance reflex. And generally in prone position, flexor tones are predominating, and in supine position, extensor tone is predominating. So in general you can remember this. Third, you see the midbrain reflexes. So now midbrain reflexes is absent in the CP. because higher center is not developed, or it is delayed. So usually these are absent in CP child, so you should check also. Writing reflexes, it should appear by 4 months, disappear by 2.5 years. So here writing reflexes will not be present. So these reflexes help align body and head with gravity. And then you check the neck writing reflex, baby supine, like put the baby in supine position, turn head, body also rotates in the same direction. And then body writing reflexes, labyrinthine writing reflexes, tilt the child in various positions, child will try to balance. This is another balancing reflex. And then optical writing reflexes, and another midbrain reflex is Landau reflex. So you should check all these reflexes in detail. Let's see the difference between the tonic labyrinthine reflex and labyrinthine writing reflex. Many people, they get confused with these two reflexes because labyrinthine name is same, but these are two different things. So tonic labyrinthine reflex is a primitive reflex, whereas both are balancing reflex, and they try to maintain the head position, but they are differing in function, timing, and then purpose. So tonic labyrinthine reflex is a primitive reflex, whereas labyrinthine writing reflex is postural reaction. Tonic labyrinthine reflex is since birth it is present. Labyrinthine writing reflex, it appears only after 2 months to 3 months. And function of tonic labyrinthine reflex is induces muscle tone like flexion, extension, whereas labyrinthine writing reflex keeps the head upright. Stimulus aid head position versus gravity, whereas in labyrinthine writing reflex, body and head tilt. If you tilt, and then they bring the head to the center. And duration disappears by 4 to 6 months, tonic labyrinthine reflex, whereas labyrinthine writing reflex, this balance will stay lifelong. Then lastly, 4 number, you check the cortical reflexes, which are also absent in cerebral palsy child. So here you start with the number 1 cortical reflex is equilibrium reaction. So these are balancing reflexes which is appearing by 1 year of age. So if the child is 2 years of age and you do all these tests, it is absent, then it will indicate this child is having cerebral palsy. Equilibrium reactions can be in a sitting and then standing position. So sitting equilibrium is, you can just follow the picture. Child is put in a sitting position like this, pushed to one side, and then arm gets extended with fingers open, and then neck corrects, brings head to a neutral position. So you can see this picture, arm on side towards which he is falling. So this side the child is falling. So here you can see arm is extended and the fingers are open like this to take a support, and they try to balance the head in the center. So this is a sitting equilibrium. Then comes the standing equilibrium. Here you can follow again the picture. Standing in the child is brought to the standing position, push the child to one side, and if you do this, leg gets extended towards the side which the child is going to fall, and the other neck is flexed, so that way they control. The side which the child is going to fall, they extend the leg, opposite leg they are flexing. So you can see these two pictures, how the child is balancing in a standing position. Number 2 cortical reflex is the parachute reflex or parachute reaction. This is a protective reaction. Here the stimulus is hold the child in ventral suspension like this and suddenly lower him towards the couch. If you do that, response is arms extend as if he is trying to protect himself from falling. So this is a parachute reflex which stays throughout your life. So this reflex is absent in cerebral palsy. So you should do this examination and check these reflexes. Then you go with the musculoskeletal examination. So here you check the contractures, check the Achilles tendon which is very taut, whether there is any scoliosis, and then check for the limb deformities because of the contractures. And different types of gait you should notice. One gait they have is a crouch gait, where the hip is flexed, knee is flexed, and then leg is dorsiflexed like this at the ankle. Videographic gait is also helpful for evaluation if the parents can bring, or you can even click the gait. There might be other gaits like hemiplegic gait, toe walking, scissoring gait. So all these are different types of gait which may be present in a cerebral palsy child. Then you go and check the developmental milestones like you check for the all children, normal children. So you check in all domains like gross motor, fine motor, cognitive, speech, language and socialization. For this also few classes I have already presented. You can go back and check my previous lectures, and then few developmental milestones I'll do in detail later. Then number 6, functional assessment is important. So here current level of functioning you should check. So this means the self-help and the adaptive skills, how much adaptive skills the child have, like feeding, dressing, brushing teeth, all these you can see. Broadly you can follow this gross motor function classification system and then label the child as level 1 to 5 depending upon the capacity or ability to walk. So this gives you another classification for cerebral palsy. So this also you have to check. Then you go and check for the associated problems. In the history also I had mentioned, and in examination also you have to check all these points. So associated problems can involve the eyes, vision, hearing system, ear, speech defects. Child may have seizures. There might be mental retardation or intellectual developmental disability and behavioral abnormalities, orthopedic dental problems, feeding problem and constipation. These are few problems. The systems involved can be eye. So in the eye, 50 to 70% cases of cerebral palsy child has eye problem like refractive error, strabismus, gaze palsy, cataract. So you should consult the ophthalmology department. 10% cases may have a partial or complete deafness, and 50% cases there might be dysarthria, aphasia. So this includes the ENT department. And seizure is one of the common manifestation in a cerebral palsy child. There can be various types of seizure like generalized, tonic-clonic, focal or multiple type of seizures, and many times 25 to 30% may have a refractory seizure which is difficult to manage. Then 50 to 75% may also have a mental retardation or intellectual developmental disability. 30 to 50% has a behavioral disorder. And then you need a orthopedic and dental problems are there. So dental department, orthopedic department should be also involved. And behavioral disorder, many times we involve the child psychiatric department. And there can be feeding difficulty with drooling, so you should take care of the nutritional programs or how to feed the child with the adequate calorie and protein. Then you go with the other system examination as you do for the other children. Like respiratory system examination is important because they have a recurrent aspiration pneumonias. Many times they are just lying and the respiratory effort or muscles are weaker. And then abdominal examination, check for hepatosplenomegaly. And then cardiovascular system, maybe cardiac murmurs can be associated. So you check the other systems also like you do for other cases. So this is one of the figures showing you spastic diplegic child with a CP. CP can be quadriplegic. This is one of the most severe. All 4 limbs are equally involved. Diplegia where all 4 limbs are involved but the lower limbs are severely affected than the upper limb. Hemiplegic CP, half of the body is involved, right side is more common and upper limb is more affected than the lower limb. And triplegic, 3 limbs are equally affected, 1 limb is spared. And monoplegic, only 1 arm is severely affected. So these can be varieties of presentation of the spastic CP, and spastic CP is one of the commonest we see in our clinical practice. Okay, thank you. I hope this class is going to be helpful for you all for your examination. Thank you.